now we are going for our master class. Now I request Dr. Harishankar Pato, who is the present chairman of the API West Bengal branch, to introduce our chairperson and to start the proceeding. Harishankar, please.
Good morning. On behalf of API West Bengal and ICP Forum of I welcome you all in this master class program. In fact, with the active initiation of our chairman, Dr. Amol Kumar Banerjee, and course directors, we are day by day we are improving our quality of master class program. We have different topics of your interest. I will advise you all to interact with the speaker, you ask the questions and clear your confusion. So today's speaker is very renowned neurologist, Professor Sandip Pal. He is at of Neurology, Medical College, Kolkata. And in fact, his area of interest is cognitive neurology and neuromuscular disorders, and very much related to the present topic. So I hand over to Professor Pal, and I request him to introduce the speaker and the subject as well. Thank you.
Thank you,
over
sir.
To Professor Pal, please.
Thank you, sir. This is a great pleasure for me to be a part of this session, because I do love this subject of dementia and cognitive neurology. And Otunu is one of my best friends, so I will enjoy his speech. Now, to introduce dementia, most of us have some amount of reservation on these topics, as because dementia is more or less equivalent to a progressive disorder without any apparent therapy. I do agree largely with this concept. However, there are two things that I will highlight to the students as well. One is at least 10 to 20% of dementias are treatable, and this is our motto, to diagnose those cases first. And second is to know the biology of our brain, because even when you are not seeing those patients of dementia, other sphere of neurology like stroke, demyelinating disorder, any other things, this biological concept will help you to reach to a proper diagnosis, proper analysis of the history. Now, differentiating dementia from other disorders as far as approach is concerned, you have to rely at least 90 to 95% on history, because in our society, we do come across those patients who are very moderate to advanced cases of dementia. Otunu is one of my best friends, and we are working in Bangalore Institute of Neurology simultaneously. And he has been seeing these cases for at least last 15, 20 years. And now he is the convener of cognitive subsection of our Indian Academy of Neurology. He is very meticulous on seeing those cases, and his approach will help our students much. Now over to Otunu.
Good morning, everyone. First of all, I'd like to thank the organizer, particularly the API West Bengal branch, for asking me to speak on this forum. And I also thank Professor Nilankanti Rai, who is my senior and a very respected teacher, for asking me to speak the subject which chairperson has already told does not attract much attention or interest among the students, but I will try to make this simple so that At the end of this lecture, the people will not find it difficult in their clinical practice. Rather, it is very important for all of us to know something about the cognitive neurology. And because cognitive impairment is so common, not only in elderly persons, but also in younger individuals, and knowledge about how to approach this is very important to make an early diagnosis and clear diagnosis so that effective therapy can be given if there is a treatable condition. So let me just share my screen. As I was talking about dementia, but dementia is one aspect of the cognitive impairment. And nowadays, the dementia term is no longer preferred because there is a stigma to this, because dementia means a person is cognitively disabled. We do not want to say any person disabled. So that's why the DSM-5 gave a new terminology called the neurocognitive dysfunction. That means the cognitive impairment resulting from neurological diseases, various organic brain syndromes, and it varies from minor to major neurocognitive dysfunctions. Now, my outline of my lecture will give you a spectrum of the cognitive disorders, then how to probe for cognitive dysfunction, how to determine the cause for it. It may not be a sequence, it may not follow the sequence as I have outlined, but I will try to cover these subjects. Now, something about cognition. This is very often used term. This is from the Wikipedia. It refers to a mental process of acquiring knowledge through various senses, to perceptions, from visual, auditory, other senses, and understanding through thought, experiences, and the senses. Then we process this information in our brain and we act to guide our behavior. This whole process of receiving, then synthesizing the thought process, then behave or acting upon is called the cognition. It encompasses many aspects of the intellectual functions like perception, attention, formation of knowledge, memory, working memory, judgment, evaluation, computation, problem solving, decision making, and of course, the language function is very, very important of other aspects of the cognition as well. Now, as we know that brain has different areas of specialization. We know that the visual cortex receives information from the eyes and helps us to see an object. But that is not all. It also has some other aspects of the brain that are connected with the visual cortex so that the seeing an object doesn't make to identify the object. It requires locating the object in the environment so that we can reach to that object. So that requires a connection from the occipital cortex to the parietal cortex. And identifying the object, looking at a building, identifying that this is Writer's building requires your recognition of the object, requires identification, and your memory store has to be taken into account so that you can identify that this you have seen this building earlier. So this is matching with that of the Writer's building. So this is Writer's building. Seeing a picture of a woman, you can identify that this is the picture of Margaret Thatcher. So that requires your memory storage to be retrieved. So that requires our occipital temporal connections. So there are association cortexes. So not a particular brain area functions independently. It functions through a network of connections. Like a computer, there are inputs, there are processing within the computer, and there is output. In the brain also, we have input, cognitive processing, and this comes out as a behavior, as an output. So this is very common complaint in any elderly individual we often come across. Many elderly person after the age of 40 or 50, they complain that they forget names, they misplace objects quite often. Do they suffer from dementia? Probably not. These are very benign complaints and they do not require serious attention. But studies have shown that this subjective memory complaint is a forerunner of future development of dementia. So we should not ignore them. We should not brush aside. Maybe these subjects needs to be followed up, particularly if they are having risk factors, particularly the vascular risk factors, or if there is having a family history of dementia. But to call these subjects are normal, you need to test his cognitive functions. At least minimum amount of tests should be done. Now coming to another story. This is the story of a 70-year-old gentleman who complained of forgetfulness of recent events. He needs reminders, carries a list of items to market, but can do all his activities in his life normally, shopping, his financial transaction, decision making, everything. He doesn't have any vascular risk factor, never had stroke, clinical examination was normal, and the mini mental state examination score, which we usually do to test the cognition in the bedside, the very screening instrument, the score was 26, just below that of the normal range. And the CDR, the clinical dementia rating score, was 0.5, not to the tune of calling it dementia. So he was almost normal, but detailed testing revealed that he had poor recent memory. Apart from that, this recent memory test, he could not recall the list of items given to him properly. Apart from these, other cognitive domains were normal. His investigations were all normal. So what will we call? This is not exactly normal. It has poor memory. Apart from that, the cognitive functions are normal. So probably he is suffering from something more than what is normal to that age. That is called mild cognitive impairment. So this is a spectrum of cognitive decline. If we say that this person of 70 years old is an individual performing normally according to his age and education standard to that in the community or other persons like the other persons, so that is called the age consistent memory loss. A memory loss will happen to any individual once we grow older. Will not remain the same as that of a 25-year-old student. If that remains same, it is called supernormal, or almost that is impossible in normal individual. But when it declines, the processing speed becomes slower, the fluid intelligence becomes lost. That is consistent with age. That is not abnormal. That is age-consistent memory loss, and this need not be treated or need not be worried about. But when it falls below that of below the performance of an average age-matched, education-matched individual in the community, but they function normally in the community. They can do their work in the home, in the office, outside the home. So that is mild cognitive impairment. But when this cognitive decline leads to disturbance of these activities in the daily life, this is called dementia. So this is the spectrum of cognitive decline in an elderly individual. So as I was talking about, DSM-5 said it classifies cognitive impairment 2. There is a spelling mistake. I'm sorry for that. The second part is the minor neurocognitive disorder. The major neurocognitive disorder, dementia, means the significant decline of cognitive function more than one domain, not only memory. That may be language, or business constructional ability, or executive function, multiple domains, so more than one domain. Maybe the social cognition, which is a newcomer in the cognitive domain. And of course, the person or the family member must have a concern for decline that they brought to the patient that because this person is having cognitive decline, and on testing, you find that there is substantial impairment of the cognitive function. And it is interfering with the independence of the everyday living. All these make a person having a major neurocognitive dysfunction. But when there is minor neurocognitive dysfunction, modest decline, there is a concern for that, modest impairment documented by cognitive testing, but there is no difference in the independence of daily living. all these to be tested when the person is not in delirium. So not in an acute phase after the stroke or in an acute metabolic encephalopathy or post-operative period. Don't make a jump to a diagnosis that this person is demented. Wait for the delirium to recover and assess that person after 1 or 2 months. And then if the cognitive impairment is detected, it may be having a dementia. Dementia is a risk factor, strong risk factor for having delirium. And there is no other cause for mental disorder. This is organic brain dysfunction. So there is no psychosis, primary psychiatric illness. And it can be classified according to the type of the dementia. So this is DSM-5 classification. So this is in nutshell how we define dementia. Dementia is the acquired loss. A mentally retarded individual cannot be called demented because this is not acquired. He has learning disability since birth. But something which is there, if it declines from the previous level of functioning. And memory is the core feature, of course. Memory is not the only feature for dementia. Other cognitive domains like language, visual construction, praxis, gnosis, executive function, and of course the social cognition. Of course, there is no delirium and it is to be interfering with the steady activities of daily living. So dementia constitutes 3 aspects. There are 3 pillars. One is the impairment of the cognition. There are plenty of behavior and neuropsychiatric symptoms, delusion, hallucinations, anxiety, depression, and there is disturbance of the activities of daily living. So this is an old scan. When the PPR compound first came in, it detects the amyloid deposition in the brain, and it can make a diagnosis even in a cognitively normal individual if the person is having a genetic susceptibility, or if the person is having a positive, strong family history. For that, if you do a amyloid scan, if you find that there are bright signals in the brain, you can make a diagnosis that this person is having Alzheimer's disease in his brain. It may not qualify for dementia. So it was in the earlier phase, it was used to differentiate whether the MCI subjects are harboring the amyloid pathology in their brain or not. This amyloid scan can give amyloid positive MCI or amyloid negative MCI. So this is a very beautiful scan. Now other compounds are here for the amyloid scanning. So this is the natural history of Alzheimer's disease, the most common dementia in worldwide as well as in our country. So everyone should pass through this phase of MCI. So dementia, Alzheimer's disease cannot happen all of a sudden. It has to be a slowly, gradually progressive disease over the years. Even the normalcy may be detected with the help of amyloid or tau scan in the brain. So what is the disease burden in the community? There are various prevalence studies available in India, but all are done independently, and there are many varied estimates ranging from 0.6% to 3.5%. Overall, above 60 years of age, 3% of individuals are having dementia. Mild cognitive impairment is almost 14% to 15%. We studied in our country sometime back in 2003. But the prevalence increases as the age increases. After the age of 60, it increases exponentially, and the women suffers more than the men. And the future projection, this is 2010 study of Dementia India study, which says that, that in 2020, there are around 5.5 million people of dementia live in India. It will increase to 7.6 million in 2030 and to almost more than 15 million by 2050. So you can imagine in your lifetime, you'll see more and more number of patients of dementia in your clinical practice. So you need to have a better understanding about the subject. This is a very common symptom. Most often you may have come across in your family, a person's having a progressive loss of episodic memory loss. Often loses his necessary items. It started with benign complaint, but it progressed to missing appointments, forgetting to bring objects. Then he forgets what he has eaten in his meal, forgets to the daily date, month. Then he had repeated episodes of unable to use telephone, television remotes, cannot recognize familiar persons. Then he developed some delusional thoughts, developed some hallucinations that somebody is there in his home. Then they developed incontinence. So this is a progressive disease over around 5 or 6 years time. This person was hypertensive and diabetic, was some good control, non-smoker, no family history of dementia. Jail examination was unremarkable. He was very well dressed and with social graces, but his analysis score was very low, 9. He was not depressed, and the CDR, it was 3. That means moderate severe dementia. So this is a video of the gentleman. Stick. এটা তো হাঁটার জন্য লাগে। না আপনি দৈনিক জিনিসপত্র ভুলে যান? দৈনিক যে আমি একটা যেটা মর্নিং ওয়াকটা রেগুলার আমি করে যাচ্ছি, তাতে আমি এখন বাদ দিয়ে ক্যাম্পে দিইনি কিছু। ভেরি গুড। স্মৃতিশক্তি কেমন আছে বলে আপনার মনে হয়? স্মৃতিশক্তি ভালো, বেটার, মানে আমার আগেকার থেকে ভালো। তুমি চেকটা কি একটু ভয় পাও না? মানে সাইনের সিগনেচারটা একটু অন্যরকম। সিগনেচারটা কি করব? আমার একটা সিগনেচারটা চেঞ্জ হয়েছে। আমার ওখানে আরেকবার যদি ওরা করে নেয় আমার ভালোই হয়। আচ্ছা, সিগনেচারে কি আছে? ব্যাংক চেকে কত টাকার চেক লিখবেন, ডেটটা কি, সেগুলোকে বলে দেয়। আপনি ব্যাংক বলে দেয়, ব্যাংক যদি দিয়ে যায় ঠিক আছে, না ব্যাংক থেকে। And listen to, আমি সেটা শুনিনি আর কি এরকম আলোচনা দিতে। হ্যাঁ, তোমার ওটা হয়ে গেছে, কথা বলছে হয়তো। হ্যাঁ, মানে কাউকে একটা ফিল করতে সে বসে আছে এবং পরে আমাকে তার নামও বলছে, ও তো অমুকে বসেছিল, তো এই তো পাশে বসেছিল। আমি বললাম, না তোমার পাশে কেউ বসে নেই, তাহলে তো পোষণ রয়েছে, ঘর খালি, কে বসে থাকবে? তুমি তো বসে টিভি দেখছো, আর তো কিছু বিয়ে করছো না। এরকম গানের বিয়েগুলো খুব ভালো লাগে। যখন নাকি আমরা থাকি তখন অতটাই করি না, কিন্তু একা থাকলে তো আরো বেশি। হ্যাঁ, আপনার সাথেই তো আমার কথা হয়েছে, আরে ওটা তো টিভি চলছে। তখন আমি খুব বেশি মাত্রা আমি বলছি না, কিন্তু হয়ে থাকে সেই পয়েন্টস গুলোই আপনাকে। So you can imagine this person was having difficulty in communicating properly. He cannot make a coherent speech. He forgets. He has difficulty in writing mistakes. So he was very advanced dementia, and he also has the delusion that the person in the TV is talking to him. His investigations are remarkable. The basic investigation like thyroid function, vitamin B12, and MRI showed a very typical loss of hippocampal volume, and there was medial temporal lobe atrophy. This was quite known Alzheimer's disease patients, quite advanced. But not all patients of dementia, they come with a memory problem, like this individual. Yes, profound difficulty in speaking, communicating. Yes. And this individual, she was quite young, but she was not having any memory problem. What she had was difficulty in using her hands. So cognitive dysfunction doesn't mean that the memory will always be there. She has difficulty in using her hands, cannot use her fingers to hold the brass, cannot comb her hair, and when we tested her praxis, she was unable to make a gesture, copy the gesture of the examiner. So this is a loss of praxis. So you can understand that the different domains of the cognitive functions can get impaired and can impaired very early without affecting the memory. So dementia often presents, often noticed by others, not recognized by the person himself or herself, but very worried person, they come with the complaint. But complaint from the family members very essential. They're often precipitated by another events like holiday or moving house. Often the elderly parents are brought to the city and they are kept in a flat and they develop the features of dementia. Death of a spouse may reveal previously unnoticed problems, maybe hidden problems, may become overt. But as chairperson said, the informant history is very, very essential to make a diagnosis, clear diagnosis. When you suspect, I think it is very essential to suspect any elderly persons to have some amount of cognitive impairment. If we approach it this way, we can detect cognitive impairment and we can help him to prevent the loss of cognitive function in the future. It's particularly those persons who are having vascular risk factors or having vascular events like myocardial infarction or ischemic heart disease or having the TIA or stroke in the past, they need to be screened periodically. Having other neurodegenerative disorders like Parkinson's disease or progressive supranuclear palsy, even the ALS patients, they are at risk of developing cognitive impairment. We have done studies on the ALS, on PD patients, those who are asymptomatic, they can have cognitive impairment. And that, if we do not address to that, that would add to their disability. Having systemic diseases like the obstructive sleep apnea, the COPD, collagen vascular disease, alcoholism, or those who are having HIV infection, chronic infections, chronic liver disease, chronic kidney disease, malignancy, they are at risk of cognitive impairment. And everyone at least should undergo some amount of cognitive testing, at least periodically, to detect early impairment. Late life depression and psychosis is very important marker of the cognitive impairment in this patient. History taking analysis, this has to be done very carefully. Detailed analysis of the presenting complaint. Many of the individuals, they come with memory complaint, but if you probe that this loss of memory doesn't mean that the memory, episodic memory is lost. They may have lost their ability to communicate. Then they have lost their ability to identify any object. So loss of memory doesn't mean that all episodic memory is impaired. Sometimes a subjective memory complaint may not be taken as a, I told you that this may be a forerunner of the dementia, but you have to exclude that pseudo-dementia aspect also. Many worried individuals, particularly those who are having, those who are young, they may come with a complaint of memory impairment, and careful assessment will help you diagnose that this is not dementia. Onset and progression and evolution of the symptoms help you understand what type of cognitive impairment the person is having. If it is subacute onset, a treatable condition can be there. Or if it is chronic progressive, it may be degenerative disease. Some amount of cognitive preservation can be achieved with the help of early intervention. Symptoms pertaining to each domain. If the person is having only the memory symptom, look for the other symptom like the language dysfunction or the executive dysfunctions. Take proper history for that also. And a careful history of the behavioral and psychiatric symptoms. So each and every aspect of the dementia needs to be probed by taking due time so that we can evaluate as a whole and functional activity of the subject. It is very often in Indian community, elderly persons are not challenged. They are kept in the home that they are old. They are not allowed to go for shopping. They are not allowed to go to the bank. So do not feel that this person is cognitively, functionally normal. He is having impairment if they are challenged. Of course, the vascular risk factors and the genetic risk factors, family history of dementia, family history of psychiatric illness, family history of any neurodegenerative disease needs to be taken in the history. Careful neurological examination, everything, I will come to that. Assessment of the higher cognitive function. Students usually do not want to do this but I will give a simple idea of how to go for it. There are simple batteries, screening instrument like mini mental state examination, like MOCA, or the Edinburgh cognitive examination, which helps you to formulate what are the aspects of the cognitive domains that are affected. You do not have to do all tests together. Attention, language, memory, visuospatial, these functions you have to identify which function is deranged from your screening instrument. Then behavior, check for the abnormality from the caregivers, neuropsychiatric evaluation, and activities of daily living. Attention is usually tested by digits forward, digits backwards, digit span. You can ask the person to repeat a three-digit number, four-digit number, five-digit numbers, such a you can find out the digit span, the forward digit span, the backward digit span. Language, most important. If you are in a hurry, ask the person to name the name of the flowers or name of the fruits in 1 minute time. You can check his fluency, his comprehension, and also most of the time, this is in a busy clinic, this is what you can do to test for the language. But if you want to test language in detail, you have to test for the comprehension, the naming, repetition, reading, writing, everything. We usually do a word list memory task to test for the recent memory, but the visual memory needs to be tested separately. Visuospatial skill is usually tested by asking the person to copy some drawing, intersecting pentagon in MMSE, or asking to draw the face of the clock. Executive function is set shifting ability. The trail making test used in MOCA is very important aspect to help you to understand the executive function. Other aspects can also be tested with different testing. This is what is MOCA, is a very simple test, can be used bedside, takes only 10-15 minutes time. And we have adapted the Edinburgh cognitive examination in Bengali language for the literate and also in illiterate versions. That can also be used. This is the Edinburgh cognitive examination in Bengali version. Now we are using this in our clinic and also for our study. I'm not going into detail. From the history and analysis, you can jolly well exclude the cause for delirium. If there is rapid progression, you can suspect that this person is probably having autoimmune or CJD. If there is a seizure, it probably underlying cause may malignancy, or there may be a past history of stroke. Walking difficulty, motor feature, Parkinsonism, or NPH could be the diagnosis. And of course, there is other aspects I have already highlighted here. We have to carefully take the family history when there is nothing. It may be a minor or very patient's family member. They do not want to disclose this. You have to take a clear history from the family members. Examination, the vision hearing has to be tested because this hearing impairment makes a cognitively impaired person more disabled. So you have to test that and allow for the hearing to be rectified or vision to be rectified. Then, of course, neurological examination, detailed examination with eye movement examination, motor system examination, gait examination, and of course, the release reflexes to be tested. Investigations, we usually ask for as routine testing, including thyroid function, liver function, renal function, vitamin B12, hypovitaminosis, B12 can cause a cognitive impairment like that of the Alzheimer's disease in elderly individual. Of course, brain imaging is very essential. In these days, MRI is needed. Optional, of course, the puncture. When you are suspecting an infection or you are suspecting an autoimmune encephalitis, you need to do a lumbar puncture. And of course, in an NPH patient, you have to tap to look for any improvement. Some other testing are sometimes needed. FDG PET is available in the city, and it is done to look for the areas of the brain hypermetabolism so that you can specifically say what type of dementia he is having. And one need to exclude that patient is not in delirium, not in depression, and MCI patient is not stamped as dementia. So this is how pseudo-dementia is differentiated. I think this need not be repeated here, but usually the dementia patients are younger. There is subacute or acute onset, and there is a particular pattern. Many of the tests, they are inconsistent. They wouldn't respond that they do not know. They do not try for any questions to when asked. They do not have any vegetative symptoms. They have vegetative symptoms like loss of appetite, bowel dysfunction. They may have anxiety or depression symptom, and particularly when all these are absent, you have to take into account the family members and detailed assessment by the psychiatrist. So in an elderly person above 40 years, if there is a cognitive symptom, you have to rule out delirium. And if there is profound alteration of the affect, rule out depression. And sometimes it may not be easy to look for whether the depression is the part of the dementing illness or depression is the cause for the cognitive impairment. So in that case, the usual protocol is treat for the depression, look for whether there is an improvement of the cognitive function. That means if the depression is treated and the cognitive function improves, probably if the dementia is not the diagnosis, it is because the depression, the patient was demented. That is a technical clue. But if there is progressive decline of the cognitive impairment with more than 2 domain affected, ideally affected dementia, and the FDL is not affected, then it's MCI. When there is lab abnormalities suggest a toxic metabolic impairment, you can make a diagnosis of treatable cause, fluctuating course, can have a vascular cognitive impairment, or maybe because of some chronic delirious conditions, metabolic impairment, sometime maybe treatable. So fluctuating course can give a clue that it might be treatable, but there might be a degenerative disease also, the DLB, Lewy body dementia, which may have a fluctuation day in and day out. But if there is slow progression, maybe subcortical or cortical, subcortical, cortical. There was old terminologies, but we still use this to make a clinical distinction in our clinical practice. Cortical means this person's having aphasia, agnosia, apraxia, but subcortical usually have profound features like abnormal posturing, stooped posturing, bradykinesia, there is pyramidal signs. Then they have sphincter involvement. So, and the memory impairment in cortical dysfunction, usually the learning deficit, whereas in subcortical dementia, it is the retrieval deficit. If you give cue, the patient's memory function improves. So this way, we can differentiate whether cortical dementia like Alzheimer's disease or frontotemporal dementia from the subcortical dementia like the Parkinson's disease dementia, Huntington disease dementia, or HIV dementia. The common type of dementia are Alzheimer's disease, vascular, and mixed dementia. These are the 3 main common causes in the community. Rare degenerative disease are frontotemporal dementia, Lewy body dementia. One need to look into whether there is any treatable cause. I'm not telling that all these conditions are treatable. They are amenable to treatment if they are treated very early, like the infection, chronic infections, chronic subdural hematoma, normal pressure hydrocephalus, vitamin deficiencies, traits, endocrine dysfunction, nowadays autoimmune encephalitis, drug toxin, and vascular dementia. It is not treatable, but if we can prevent the further damage to the brain, and you can help the patients to live a normal life. These are some of the treatable conditions, although this multiple NCC will not recover completely, but it is treatable if it is detected early, and subdural hematoma. And this person, they can see the gait of the person. If they come early in the phase of the walking difficulty, when the cognitive impairment has not started, or it started just with some impairment in their cognitive function, subcortical type, you can make a diagnosis, you can ask for the shunt surgery. Now, these are some of the stories of the vascular dementia patients with type 2 diabetes mellitus, smoker, hypertension with 3 different strokes, having difficulty in walking, spasticity. Usually the cognitive function is ignored because these patients are more concerned about their walking difficulty, their motor problem, there's communication problem. But if they are tested, they're usually having depression, apathy, and they do not respond to the treatment because they are reluctant because the cognitive process is not helping. So vascular dementia is very common in our country because vascular risk factors is common, and also the strokes are very, very common in our community. So it can be with focal signs, with abnormal imaging, and you can make a diagnosis after stroke, but you need to wait for 3 months to make a diagnosis of vascular dementia. Abrupt onset stepwise progression means multi-infarct dementia, but that doesn't happen always. Some small vessel disease can have a very slowly progressive course. Strategic infarct dementia, only one infarct can lead to or infarct on the bilateral caudate nucleus can lead a person to demented with psychomotor slowing. Similarly, the stroke in the left thalamus or paratotemporal or parado-occipital areas can make a person demented. So these are strategic infarct dementia. And of course, this is a story of a 65 years old hypertensive individual with 15 years history of coronary artery disease, progressive loss of recent memory, apathy, depressed mood, psychomotor retardation, and walking difficulty, incontinence. There was no history of stroke or TIA. He had bilateral pyramidal signs. So he was hypertensive, he was aged, and these MRI shows have been showing that disease. This is a story of looks like that of a degenerative disease, but if you do MRI, and you'll find that there is a significant white matter abnormalities, and this has been shown that disease. So subcortical vascular dementia is common in our community because of the high prevalence of hypertension and uncontrolled hypertension. So white matter changes, lacunes in the brain MRI, and they usually present with incidence onset, slowly progressive cognitive impairment, memory impairment, that memory function improves with cues, but they are most having executive dysfunction, having lesser amount of visuospatial defect. So what is the clinical criteria of vascular dementia? Must have dementia with evidence of coronary cerebral vascular disease, vascular risk factor, focal signs, vascular changes in the imaging, and probable association between the two. Sometimes the cognitive pattern may not match with the vascular dementia. So in that case, it is like both in combination of the degenerative dementia and vascular dementia, we make a diagnosis of mixed dementia. That is also a very common entity in the community. Now, something about the Parkinson's disease dementia. This is an individual who came after a few years of diagnosis of Parkinson's disease. You can make out his voice, his expressionless face. Here he describes how he sees many persons sitting on the sofa besides watching the TVs. But his wife says there is nobody. But he always tells that he sees this person comes and sits on the sofa along with him, watches TV. So that is a clear, vivid hallucination this person was having. So he was a retired teacher. He had fall and fracture neck of femur. He was delirious. He didn't recover fully. He had visual hallucinations. On examination, he was having Parkinsonism. There was fluctuation, some good days, some bad days in his history. There was history of REM sleep disorder. He used to kick his wife on bed. Sometime enactment of sleep, enactment of dream. And on examination, he was reduced attention, executive dysfunction, during bad days, visuospatial dysfunction, poor memory, and with retrieval deficit. During bad days, it was difficult to test, but he came when he was with a sound mind, he was having executive dysfunction. So this is a diagnosis of Lewy body dementia. Now, another patient who is a 56 years old gentleman who came with just 3 months history of behavioral dysfunction. She was a lady with attention deficit, progressive memory loss, anxiety on trivial matters, along with loss of interest in the daily household affairs. So it was a rapidly progressive over 3 months' time. There was a fear of loud noise, visual hallucination, becomes stooped, slow, gait becomes difficult for him, had to walk, hypoponic speech, and then become unsteady. Examination is revealed he was having a kinetic rigid state, no coherent speech, stimulus sensitive myoclonus, and hyperreflexia. So the main concern here is the rapid progression of the disease and makes this lady bedbound within 3 months of time. So he was investigated in detail because we tried to find out any treatable cause that can be treated. So there was nothing in the routine examination, including the anti-TPO antibody. The CSF autoimmune antibodies are also negative. The spleen CT scan was normal. But our EEG showed periodic spike and wave discharges, and the MRI showed classical hyperintensities in the DWI and the flare sequences in the basal ganglia, suggesting that this is a clear incurable disease of CJD. But all rapidly progressive dementia are not like that of the CJD. This is a very young girl who came in a 9 years age. She came with a progressive cognitive decline with loss of speech, abnormal posturing of limbs, unclassifiable seizures with altered sensorium. MRI was normal. Her NMDR antibody was positive. She was treated with methylprednisolone. This was after her treatment. She recovered and she could be able to walk. She comes regular follow-up. Now she is on periodically. She now goes to school and she is now a success story of persons already with recurrent generalized seizure for 2 years. On every occasion, she was told that seizures are due to hyponatremia. So she was not on any regular. Came with behavioral disturbances for 1 year. When she came to us with irritability, poor social communication, and abnormal movement of her face and mouth for last 6 months. So we are having a disease of 2 years duration with recurrent hyponatremia, with 1 year history of behavioral abnormality and movement disorder, particularly orolingual. On examination, she was disoriented with slurred speech, orolingual dyskinesia, generalized rigidity, and there was no myoclonus. So this is the patient. She was on parenteral nutrition, unable to speak properly. There was orolingual dyskinesia. So what we did, we investigated and we found there was a normal liver function test, normal thyroid function, other anti-TPO was normal. Chest scagogram was also normal. The MRI brain was normal. CSF showed almost normal CSF with positive anti-LGI1 antibody in the CSF, suggesting autoimmune encephalitis. And probably this hyponatremia was the clue for these patients. So this patient also was treated with methylprednisolone and she improved a lot, although we did not have the follow-up. So rapidly progressive dementia is an entity. One needs to be energetic in making a diagnosis, clear diagnosis. Toxic metabolic causes needs to be looked into. Autoimmune encephalitis is now almost, if you do not suspect or if you do not investigate, you can miss, and if you are not treated very early, patient may land up in a progressive cognitive dysfunction. Of course, there are some paraneoplastic autoimmune encephalitis which are not treatable in that way, but non-paraneoplastic, the NMDR encephalitis, those who are not having ovarian teratoma or a VGKC, like the LGI1 encephalitis, they are elderly patients without any underlying malignancy. They are usually well treated with immunosuppressive agents. Infections in India, there are a host of infections that can produce cognitive impairment. HIV is not that common to produce cognitive impairment in India because probably the strain is different. But syphilis in the old days, now also in the HIV era, the syphilis has come up. Lyme's disease, even the chronic tuberculosis, neurocystic sarcosis, that can also produce a cognitive impairment. Sometimes the degenerative dementias like the DLD, the Lewy dementia, corticobasal degeneration, or frontotemporal dementia, they can come with rapid progression. Paraneoplastic autoimmune encephalitis, one needs to investigate for the underlying malignancy. And this is an unfortunate story of our country, where we usually see rapidly progressive dementia with slowness of walking, abnormal posturing of the limb, gait ataxia, becoming bedbound, alternating mood state. And if you test for their EEG, you will find there is a periodic discharges with burst suppression. And if you test for their CSF, you will find the anti-measles antibodies. So the adult onset SSP can present with rapidly progressive dementia. Unfortunately, you do not have any cure for that. Mass vaccination of the nation with the measles is what we can prevent this. Now, this is another story of an insidious onset, gradually progressive forgetfulness, and mostly the behavioral abnormality for 1 year duration. Patient was untidy, patient was having apathetic, loss of interest in the family members. There was loss of same, he was not having, following the social norms, he was having food cramming, eating non-eatables, disinhibited behavior. So cognitive impairment was not that common, but the behavioral symptoms were much more common. With emotional incontinence, sometimes he was laughing without reason, and the person was quite young, only 42 years old. So she was having difficulty in understanding what she was told. She had difficulty in reading. She fails to remember recent events. She has social incontinence. There was slowness, clumsiness, walking difficulty, poor attention on cognitive examination, poor attention, executive dysfunction, recent memory deficit, and some rigidity, bradykinesia, hyperreflexia, and Parkinsonian gait. She was found to have this type of abnormality in the white matter changes, also extending to the anterior part of the temporal lobe. So this was a genetic dementia, very young onset dementia. So young onset dementia is a group of disorder which is not very uncommon in the society. We usually see almost 20% of the patients qualifying the diagnosis of young onset dementia in our clinic before the onset, before the age of 65, but most of them are in their 40s or 50s. They are unfortunate because they have the responsibility for their families. They are the breadwinner. When the dementia sets in a young individual, this is very devastating for the family. So this is the common causes of the young onset dementia is, of course, Alzheimer's, but most of the other causes include the Huntington disease, the frontotemporal dementia, the alcohol dementia, the HIV dementias, and of course, vascular dementia in our country. And many of these things have genetic causes, hereditary causes. There might be different radiological findings which may give you a clue, like that person, lady who was having a nasty mutation in their gene, in their blood. So some young, very, very childhood onset dementia you also see in our community, particularly the Wilson disease, SSPE, and of course the leukodystrophies and the Niemann-Pick type C. Rarely, although in the reference center you see these patients. This is a Huntington disease patient. This is Wilson disease patients. The wing beating tremor in Wilson disease and the KF ring. I'm not going into details. So to conclude, the cognitive impairment is common and may be found in association with many medical illnesses. A strong index of suspicion is needed to detect very early cognitive impairment. I know that it is in a degenerative dementia, you may not have the drug to offer, but it is not very far away. There are some drugs are available in now the FDA have also given permission to some anti-amyloid drug. So it may be in the future, you have to make a diagnosis very early so that you can initiate the treatments to prevent the degeneration. And each patient requires a thorough evaluation to detect potentially treatable condition. That is one important goal. So thank you very much for your patient sharing. I think
Thank you, Dr. Bishwas, for your excellent talk. I think he has covered almost everything on dementia within 1 hour. So there are plenty of questions I think the students will ask so that they will be clear about the intricacies of dementia. So it is open for discussion and students are being asked to put their comments and questions to be clarified by Dr. Bishwas.
Sir, may I ask one question? Just,
yes.
I am, hello?
Yes.
I am Dr. Tapus Banerjee. I am basically a consultant physician working in a hospital in Kolkata. So actually, recently I come across a very interesting case of a lady. The husband noticed a progressive intellectual decline in 67-year-old wife during the last 5 to 6 months. He says she forgets the address, telephone number, and on many occasions, even children's name. He also says that she sees flowers and other objects on tables, on walls, when they are actually not present there. Physical examination reveals a shuffling gait and mild hand tremor. And when I examined, apart from systemic examination was apparently insignificant, except mini-mental scale state examination, there was significantly reduced scale. She actually was on thyroxine, 75 microgram, and when we did the routine examination, actually the hemoglobin is on the borderline 10 or 11, and thyroid function is just on the upper limit, 8, in spite of taking 75 microgram. And B12 level was a little bit low, not significantly. She was a vegetarian. Now, what could be the possible diagnosis in this complex scenario of hypothyroidism, B12 deficiency, and then delusion? Because she met a few psychiatrists before coming to me. She was, the husband was confused whether actually he will consult some neurologist. That's why he came to me to actually guide him whether which type of investigation, which type of she actually received antidepressant from 2 different psychiatrists, but without any improvement. So how do we approach this case? Because it looks like definitely a case of dementia, whether it is associated with Parkinsonism or pure Alzheimer's, that is a question.
So what is the duration of the illness, sir?
6 months, sir.
Only 6 months, and there was no family history of dementia.
No, yes, I took very carefully whether any of the family members before or at that present time, there was no such history. And thank you for your extraordinary presentation.
But actually, 6 months duration of cognitive impairment
with fluctuating cognitive impairment, yeah.
Fluctuating cognition, with visual hallucinations, and the Parkinsonism. If you want to make a diagnosis, although 6 months is that to short a duration, but it qualifies for probably the diagnosis of DLB. Although in a young individual, we don't want to make a diagnosis of degenerative dementia, but having Parkinsonism, having fluctuation in the course of the disease, having a visual hallucination, and the cognitive impairment. It could be a case of DLB. I suppose her brain MRI is absolutely normal because brain MRI usually doesn't give any clue to type of degenerative dementia.
We did MRI. MRI was absolutely normal. She was a 67-year-old, and she had mild delusion also at the time of examination.
I request Dr. Pal to also comment on this case.
Yes, on hearing the history and physical examination, the first possible diagnosis is DLB. But from my point of view, there are some caveats both in the history and examination. Now coming to the history, many patients of dementia used to complain of family members used to complain of duration of 5 or 6 months. But if you probe more meticulously, then you will get the history of say 2 to 3 years, 4 years even. We used to ask the question that when the patient used to do her cooking, maintaining finances, when it has stopped, probably that will help you to indicate the onset of dementia rather than a usual duration of illness. They usually report the rapid deterioration part, not the onset of dementia. This is one thing.
Right.
Second important question that you have asked, whether it has got any relevance with hypothyroidism, and as the patient was vegetarian, whether hypovitaminosis B12 could be etiology. Right. To me, hypothyroidism part C will not produce this type of severe dementia. They may present with mild cognitive impairment, mild dementic, but the severe dementia only by hypothyroidism without any autoimmune thyroiditis, means antibody associated dementia, or just simply hypothyroidism probably cannot explain. Same thing is true for vitamin B12. If you do not get any other features of vitamin B12 deficiency, both clinical and paraclinical, just finding a low vitamin B12 will not suffice to stamp this case as due to vitamin B12 deficiency. But the odd is normal MR. We do get this type of MRI, seemingly normal MRI. There are two caveats. One is from radiological point of view, it might appear to be a normal, but to a cognitive neurologist like Dr. Ratanu Biswas, it might be abnormal. This all depends upon which patient we are seeing, whose MRI we are seeing. Then when, if it is normal, then PET will help you to diagnose whether there is metabolic deficiencies, even when the structural MR is normal.
Thank you so
much. Dr. Atanu Biswas and Dr. Sandip Pal, thank you for offering us a very good session over here on dementia. My very simple question may appear to be a bit silly. Sometimes I am Dr. P.S. Karmakar speaking, Dr. Pal and Dr. Biswas. Sometimes we do encounter quite often that patient is complaining of, recently I am just forgetting the name of persons. I cannot recall at the time of practical situations. So could it be a very early feature of dementia, or we should ignore that without any investigations?
In an elderly person above the age of 40, forgetting the name of the acquaintances, particularly, sometimes it becomes embarrassing even for us to recall the name of the old friend meeting after a long duration. It is very common to have forgetting the name of the known persons. But these are benign complaints, unless, of course, the serious memory complaints is also there. It should not be recognized as a symptom of dementia. Forgetting the name of the person, forgetting the name of the place, or even misplacing common objects is very common in any elderly persons. But in studies, it has been shown that those who are having this complaint, the subjective memory complaint, they usually are at higher risk of developing cognitive impairment in the future. But that doesn't mean that this person should be investigated in detail, unless, of course, they are having a vascular risk factor or they are having positive, strong family history. They should not be subjected to detailed investigations, and they should be assured that these are not very serious complaints.
Okay, thank you.
Okay, Sandip, anything you like to add or something, since we have not any other questions from the PGTs or any other attendees? So I think you should do some concluding remarks on the dementia. Then after that, one of our panelists, Dr. Apurva Mukherjee, will give thanks and conclude the session. I just give some concluding.
Sir, how many percentage of mild cognitive dysfunction progress to dementia, and in what time? 6 years, 8 years?
Yes, it is seen that 10 to 15% of the patients of MCI usually convert to dementia every year. So if 100 patients is a cohort of 100 patients of MCI is followed up, every year almost 15% convert to dementia. But of course, not dementia. MCI is a heterogeneous group. There are actually individuals who are having MCI main level of function over years, many years. They remain stable. Some have improved. So MCI can be because secondary to some they may improve with over time. But those who that is why it is now essential to find out whether the MCI is because of the underlying degenerative disease like Alzheimer's disease. That is why, because at this point we can intervene if the patient is having Alzheimer's pathology in their brain with that like that of the monoclonal antibodies that are now FDA has approved, aducanumab. It can be used at that point of time so that we can prevent the progression of the development of Alzheimer's disease. But we do not have the luxury to test for the amyloid scan in India at the moment. So MCI is a heterogeneous group. They may have pathology in the brain, like Alzheimer's disease, or may have a normal brain with some underlying stressor, which if we treat, that can improve or may remain stable over years. By and large, 10 to 15% of the MCI convert to dementia each year.
Thank you so much, sir.
Also, there are recently asked questions regarding first is volumetric MRI, and second question is the role of music.
Yes, sir. For volumetric MRI.
And the second question is the role of music.
Yes, sir.
For the
last question. Yes, sir. For routine MRI, as Dr. Chairperson was talking about, routine MRI gives a very important clue to exclude any treatable cause, and also gives a clue that there is a vascular load, and also some other clues like those who are having typical atrophy of the frontal part of the brain or the temporal area. But in majority of the dementia, particularly in the early phase, it is very difficult to detect any changes in the brain MRI, in the structural brain MRI. For that reason, whether the medial temporal lobe is atrophied or the parietal lobe is atrophied or the basifrontal or the medial frontal is atrophied, that requires a volumetric assessment. That requires a sophisticated MRI, and usually the 3D MRI sequence with assessment of the volume, and of course requires age-wise normative data. So this is not commonly done, not routinely done, but this is a research work and research-based work. We also ask for these volumetric studies in some of our patients, but routinely this has not been done. Rather, it is more easier to get the functional activity of the brain if we ask for the PET scan. FDG PET is available in our country and also in our city. That gives a clue that this medial temporal hypometabolism, or there is a frontal hypometabolism, or the occipital hypometabolism is in DLB patients. That gives a very clear idea about that. So regarding second question, music therapy. Music therapy has been found to be effective in any of the other conditions as well, but also has been tested in dementia subjects. But I do not have any idea about any definite role, any recommendation for music therapy, because this has not been studied systematically. And for any treatment to be effective, dementia, for degenerative dementia, it has to be instituted very early, or at least in the mild to moderate stage, not in an advanced stage, when we do not expect anything miracle to happen. So music therapy definitely has a role. Non-pharmacological therapy is playing a major role in treatment of the dementia patients. And in the daycare center or the respite care center, they are usually offered with music therapy, dance therapy, and some other non-pharmacological measures also.
Sandip, if you like, say
yes.
you do it now. And after that, you should conclude.
Sir, before conclusion, I would like to highlight one important points as far as seeing the patients of dementia. When we examine patients in any other medical fields, like examination of liver, examination of lymph nodes, even in neurological field like extraocular movements, facial weakness, deep tendon reflex, plantar, this is all or none phenomenon. Because I want to stress upon the fact that if you get hyperreflexia, I will get also hyperreflexia. There is no question about these findings. But in case of dementia, it all depends upon your assessment. I am giving a simple example. I had seen a patient 2 days back, a lady of around 60 years of case of dementia. He cannot tell what will be if you add 10 plus 10, even not 5 plus 10. You can tell that patient has a calculation problem. When I gave 10 rupees note, 10 rupees note, she instantaneously told that this is 20. When we gave 5 rupees coin, he instantly answered that this is 10. So this, I am not going into detail the circuitry of this abnormality, but what I want to stress upon that during examination, different types of cognitive domains have been tested simultaneously. You have to very careful about telling that this test is abnormal. Rather, you have to notice which domain is being abnormal so that you can group them under different categories. Like this is a predominantly a memory defect. This is predominantly executive defect. This is predominantly a language defect, like this. This is the most important part of seeing a patient of dementia. Thank you, sir.
So I take this opportunity to profusely thank brilliant speaker, Professor Autoimmune, and the brilliant chairperson, Professor Sandip Pal, for giving us an overview of dementia within a very short possible time, because this is a huge subject. And as our chairperson was reminding repeatedly, that Professor Autoimmune has done an excellent job by covering more or less the extensive topic within a period of 1 hour and enriching the students tremendously. Once more, I thank on behalf of Indian College of Physicians, the academic wing of API, West Bengal, for a huge congratulations as well as our personal thanks to both Professor Autoimmune বিশ্বাস and Professor Sandip. Thank you very much.
Thank you, sir.
Okay, thanks. Now we adjourn this our master class. Our next master class will resume on 4th of July with the topic of approach to obesity. Thanks to all.